Good afternoon, everybody. This is Tracy Johns, and I'm unfortunately not with you today. Can everybody hear me?
We can hear you.
Okay, thank you. Just wanted to welcome everybody to our May meeting for GCTE. My Superwoman co-chair, Lynn, is there, and want to call the meeting to order and get her to determine if we've got a quorum.
We do.
Okay, great. All right, and so we need to approve the minutes from our last meeting in February. Any corrections or additions that need to be made? So hearing nothing, can I get a motion to approve the minutes for February? Lynn, I'm having trouble hearing. You'll have to kind of take it from here.
Kendra approved and Kelly seconded.
Okay, great. Well, we got the minutes approved. We have a guest today, but she's caught in traffic to give us a LifeLink donor family story. Chuck, would you like to go ahead and just give your report, or would you like to wait for your guest?
We're gonna wait. We're gonna skip over them and come back when she
Okay.
gets here.
Okay. Liz is in another meeting next door. She's going to give her update tomorrow, or at the Georgia Trauma Commission meeting, excuse me. So we'll skip over that. So we'll go straight to the Office of EMS and Trauma. Is Marie there?
She is.
Okay.
She's coming.
Okay. I'll let you just kind of keep it going, Lynn, since just to make it smoother.
Okay.
Hi, everyone. I'm Marie Probst with the Office of EMS and Trauma, and I'll give a quick report on the OTCPE reports. The Q2 reports were all complete. I have good news. The level 2s and 4s were at 100% on everything. The data, their report, their trauma surgeon response, and the record closure rates. The level 1s and 3s were at 80% on a few of those deliverables. We are waiting for 5 more TMDs and 1 burn medical director to sign the OTCPE for Q3. So trauma program managers, if you could help prod poke your medical director and ask them to complete those attestations, we'd appreciate it. And we're waiting on 2 OTCPEs to be submitted completely. The Q4 form will open on June 15th. If you have any questions about the annual report, please reach out to us and let us know. And it will be due July 15th, excuse me.
And Marie, that's going to be a significantly larger report. So there's some injury prevention and other annual stuff. So it would probably be good for the TPMs to start on that a little bit early, wouldn't you say?
Absolutely. You're right. It does include injury prevention information, details about your core measures that you have tracked for the year. The old timers are aware of what's in the report, but if you are new to completing the OTCPE, please reach out to us and we'll give you a heads up of what to expect. Now turn it.
Hey everyone, my name is Stacy. I'm the state trauma coordinator. Just a couple updates from our office. We are still doing some level 4 consults and designation visits for the rest of, we have about 4 scheduled for 2024. We've also been doing some consult visits for any hospital that would like to just reach out to us. We kind of do a consult, go through if you're preparing for ACS or if you're preparing for a visit by DPH. We kind of do a little mock run through, kind of see if you have any questions or anything we can help you with to get you up to speed, or just if you just need that extra reassurance that you're on the right track to be designated. We did get a new level 2 in Region 8, so we're excited to have them on board because we know that South Georgia gap is missing some trauma centers. We do have some people that we are going to be visiting and talking with in the next couple months in South Georgia to maybe get some extra centers down there. We were glad for our 2 level 1 trauma centers got ACS verified and designated, or re-verified this quarter, and 1 moved from a level 2 to a level 1. So I know they are very excited to be putting that out there. The other updates we have with our Marie and Gina are still doing some validation visits for your data. We will work with Biospatial in the to do the Q4 data soon. Let's see. And then with the additional things for our office, our Kelly Jorner is working with Liz with the Trauma Commission to identify trauma hospitals and EMS locations across the state, and whether we need maybe more, which I know it's a shortage everywhere, or if we need some maybe more air facilities. Richard Rhodes with our office is working with the EMS subcommittee for more training course maps. We're also working with the EMS workforce dashboard and to get some more education on this dashboard for our EMS partners. And if we're also published our EMS annual report, and it's on our website as well. If y'all want to look through that, it's out there and published.
Thank you, Stacy. Any questions? Okay. Lynn, who's up next?
Cheryl, the Trauma Foundation update.
Okay. She can drive up in her Porsche.
I'll try it again. Usually I can just project and I don't need the mic. So it's good to see all of you, and the reference about me coming up here in my Porsche is because we just had our driving change and trauma care event at the Porsche Experience Center this past Saturday night. So thanks to all of you who were able to make it. It was a good time. I'll let you all talk about that, or we can talk about that later when we have our reception this evening, and I'll share with you. So when we get ready to have the next one, make sure that you come, because I think everyone who was there will tell you what an enjoyable experience it was. Even for the ladies who had their long, tight-fitting dresses on, they still managed to get in and out of the car to go around the track, and everyone looked lovely. It was a good time. Just want to share a few things with you all in the way of an update. You know that we've got the Rural Continuing Education Program initiative that is going on at this time. Ideally, our first year would have been over at the end of March. That's the way it was scheduled. We extended it through the end of May, not because we weren't able to make our goals. We actually surpassed those, but because we needed to do a few more things to make the first year be the type of foundation we want to spring forward from for the second year. So let me tell you a little bit about what we did in what was actually Q4. We, in order to fulfill the grant, we actually only had to complete or conduct, make sure 12 courses were facilitated over the course of the first year. And we had 11 in the fourth quarter of the year. So we well surpassed everything that we needed to fulfill as far as grant expectations were concerned. So in Q4, there were 11 courses with a total of 125 participants and 114 classroom hours. That's just 114 hours cumulative for the amount of time each course took. But when I give you all the report at the end of the first year, I'll total all the hours up so you'll know exactly how much educational hours were conducted through these courses. And it is a lot of them. The courses are really making an impact. We're already building a strong calendar for year 2. If you are in a rural area and you need a course, then please reach out to our office and we'll see what we can do. If we can't get it to your facility, we may be able to get it somewhere within that RTAC region so that you all can get the type of education you need soon or as soon as possible. Also, you'll remember that we have the CEED, that's the Continuing Education Instructors Database. Just want to always remind you that if you'd like to be a part of that database and be a part of the faculty that we call on when we do these courses, then we would like to list you there. So just let me know. I'm happy to get you into that database as well. Our plans continue as far as hiring an education coordinator. We had hoped to have that person on board to start at the beginning of June. However, I must say, it's because of me that we haven't brought that person in yet. I was a little busy and didn't get the chance to really get my team together to do the interviews, but we'll have a panel that conducts the interviews for that position. We had closed out the application period. However, since we have not begun the interviews, if you are interested in the education coordinator position, then just please reach out to me, let me know. I'll make sure you have the information you need to apply. And that's all I have at this time.
Cheryl, could you just very briefly remind everybody this grant that we're talking about, what it is? It's really kind of an awesome accomplishment for the trauma system to have gotten this state money for education. And so for those that might be newer, they might not be aware about it.
Oftentimes what you'll find is that when you're in an area that is considered rural, you don't have access to some of the continuing education courses that are needed. And so what we were able to do is to apply for a grant that comes from the Department of Community Health. It is administered by the State Office of Rural Health. And for that grant, we conduct courses all across the state as far as advanced continuing education is concerned. So it might be an ATLS course, an ATCN course, an RTTDC course, TNCC. There are quite a few courses that we are making sure are facilitated. And again, it's all across the state. What we do is we pick facilities that say they want to host the course, and it will be in a certain region. So if there are a lot of rural hospitals, say in South Georgia, we may partner with a rural facility down there to host the course, or we may do it at level 1 or 2 trauma center if it's close by. But we'll have a course that's hosted in a particular region. We will let the rural hospitals or the critical access hospitals within that region know that we're conducting the courses, and folks are able to sign up for them. And the good thing about the course is that it does not cost a nurse or whoever is attending the course anything to attend it. We take care of all fees associated with the course. If there are any fees that are associated as far as books, depending on which course it is, then we take care of that. The only thing we don't pay for is we're not going to pay for your travel to the course. But all the other expenses we take care of. So oftentimes a lot of people who want to attend the courses encounter a lot of expenses because you have to travel for a long, long distance, usually to get to a course. You have to pay all the fees associated with the course, and it winds up being a lot. But doing it this way, it enables folks who might not be able to attend the course to do so without any unnecessary burdens. Does that explain it?
Yes,
Yeah.
ma'am. Thank you, Cheryl.
Okay.
You've done a great job because this has kind of been learning as you go type thing. So even though this is the first year, quote unquote, it's a 3-year grant. And so I just see this getting better and better. And I'm really excited to hear about the number of courses that we just had in the most recent quarter. So that's really great.
Yeah, it's actually going gangbusters. It really is. And the State Office of Rural Health is very pleased with everything that we've been able to do in the first year. So we're going to continue to build on that. And we are going to count on many of you in here to help us get the word out about the courses. If you're in an area where there are rural or critical access hospitals, or if people are contacting you about courses and they're having problems getting in them for one reason or another, then certainly feel free to reach out to us, because we'd like to partner with whoever it is and get them the education that they need.
Excellent. Excellent. Thank you, Cheryl. I think next we have our LifeLink presentation.
How about now? Oh, yay. Hey, everybody. I'm Kim Cotterman, Director of Professional Programs at LifeLink. My colleague Chuck Massey, if you guys have seen us, Chuck joined me in this journey in trauma last summer. So we are tag teaming our work and being involved with you guys. As always, so appreciative to be a part of this group and to be able to come. We typically come in person twice a year and share data with you. We're going to mix things up a little bit today and share some more personal stories as personal story. But before we do that, I just wanted to remind everybody, I know there've been several ACS site visits over the last few months, and we have been involved in that. So please, if you know you're having a visit, reach out to us ahead of time. We're happy to put together the data for you. One of the things that we did since last time we were here is Chuck and I came up with some standardized guidelines so that whether you're down in South Georgia or you're at Grady and you have an ACS site visit, we are providing consistent answers, that we're all answering the questions the same way and based on the same metrics, which have changed a little bit over the last few years. So again, happy to help out. Let us know if somebody's coming your way. Also, I did want to give a shout out to Cheryl for the event, because the Porsche event was super fun. Chuck and I both got to be there. It was nice to see so many of you guys put on our fancy clothes and have a great night out. Just a really, I know it's been a few years since we've come together for that. So awesome job there. But I'm going to turn over to Chuck, who's going to introduce our guest.
Thank you, ma'am. So, and I appreciate Dr. Ashley being my friend and preparing me for that car ride, or else might have had a different outcome. So I was going to introduce our special guest. And this is introduction. I was like, help me with your introduction. And this is what she wrote. It says, we don't often get to see what life is like up close and personal for the survivors of a trauma-induced death. Leah Osment, the mother of Thomas, who is forever 19 years old, is here today to speak about the life of her son after his death. So if we could welcome Leah.
Where it is.
So when Chuck had asked me for an introduction, I Googled, what's the right thing? I want it to be efficient. And when it came to why am I here, it's more than organ donation. It is so much more than that. I'm here because of organ donation, but my story is to touch your heart for organ donation. While I completely respect people's decision to donate organs or not, I do feel like it's a humanity deficiency that we have. And my journey is touching hearts and has changed lives. And so I'm so glad to be able to talk to you today about Thomas. As you can tell, I strive for protection, for perfection with Thomas. This presentation may have some errors in it. The video links might not work. I don't know, but it's okay. It doesn't stress me out. I don't want y'all to say, oh, does she know that's wrong? There's an ad that shows up in one of the videos, like a little corner. I can't fix that. So anyway, I just wanted y'all to know that ahead of time. Okay, you can go next. Yeah. So I am Leah, Tom's mom. Thomas passed away on November the 17th through the 21st. I don't know what day to claim. I mean, the organ donation process is, it depends on how long it is, but the 17th of November, he had an accident. And I would really bet money on, if you had to guess what happened to a 19-year-old boy, you would guess a motorcycle accident, especially with trauma. I mean, we all know that it makes you not want your child to have a motorcycle. But Thomas, my worry for Thomas when he got the motorcycle was not that of him being irresponsible. He was a very mature, responsible child. Once he got old enough and had a job, he's an adult, and one of the conditions I set for him to get the motorcycle was Life 360. And if you're not familiar with Life 360, it's an app that you can have on your phone with your kids, and you can see how fast they go. You can see hard brakes, accelerations. And we had that when Thomas started driving, and he was always such a good driver. So I really didn't worry about that with a motorcycle, but I worried about other people. And so I talked to him about, what if you die? Because that's just the truth. I mean, this is a risk that you're taking. And of course, no child thinks it's going to happen. But we talked about it, and I talked about organ donation and, all of that with him. And about 3 weeks later, he hadn't had the motorcycle 3 weeks, and he was leaving work and an animal right out in front of him. And I got a text from Life 360 that Thomas had been in an accident or a collision, with a link where to go, where he was at. So that's the story of Thomas's accident. When I seen that I had made this post, it was very odd on Facebook, because before Thomas died, I was very private. There was nothing public about me, and I didn't even post about his accident, but I posted about the organ donation process, and I was so impressed with that I was thinking about that. Organ donation has always been important to me, but I was thinking about that at that time, and that's really amazing. We had an honor walk at Piedmont Cartersville, and it was incredible. I don't even know how many people were there. It was just hallways and hallways of people. And, that's what you want. You want to know that people are showing up for your child. And that was just a good thing. So at Piedmont, Atlanta, in the organ recovery unit, the night before Thomas went down there, Brooke, I believe is her name, she's the head nurse. And I didn't know this till after the fact, but she was trying to figure out what she could do for me and Thomas that would be meaningful. I've never got sad talking about this part ever. We did the hand sculpture. And that picture was so weird. When I seen those pictures, I don't even know how long after it was, but I was like, who took that picture and why? Like, why? And they're like, you told us to. But I'm glad now I have it, because that's the reality, of this moment. And the hand sculpture worked out perfectly. The Atlanta Journal-Constitution did a story on it, and the nurse got an award for it. So that's just a really beautiful part of the story. So as soon as I was able to really start realizing what had happened, I wanted to write the letters to the organ recipients before I even knew anything about them. I was obsessed with it, because I could not, the way it made me feel to know how these organ recipients would feel knowing they got the organ of a 19-year-old, that has to feel so heavy. And I wanted them to know it's okay. It is okay. That was my goal for that, because, the mental part of organ donation for the recipients is real. And I was thinking about them. I'm like, I got to get these letters. I got to handwrite them. They're going to know I'm okay. I can write a letter. And I mean, it was obsessive, but I got them wrote, but I did not send them until Bonnie Raitt won a Grammy for Song of the Year in 2023 called Just Like That. And it's about organ donation. A heart recipient finds his donor's mom, and he goes to her house, and she lays her head on his chest and hears her son's heartbeat. And when I was able to listen to it, it took me a minute. I was like, I got to send it. I gotta send this letter. I've got to find the heart. And that's my letters, the picture. On May the 17th, it was about 11:30 at night. I looked down at my phone. I was out on my back deck and it was a bad night. It was just a bad night. And I looked down and I seen an alert. This is a Facebook group that maintains a registry that you can put your cell phone as a donor family or a recipient. And a lot of people are able to connect that way. This is how they found me so quickly. If they would have wrote a letter, it probably would have took 3 or 4 months to get back to me. And it was perfect timing because May the 17th, I seen that, and that is one of the best nights of my life. Like literally, that can never be topped, the way it felt to know that Thomas's heart was okay, you know, because that child had such a good heart. That is Jason and me and my oldest son FaceTiming that night. And on May the 17th, I said, well, I'm off work for Thomas's birthday on May the 31st. Jason lives in Ladoga, Indiana. And I was like, so do you mind if I come up? And they're like, sure. And I said, well, another thing is I've got NBC News working on this because when Thomas died, y'all seen that picture of him. He is a beautiful child. And I just wanted his face on the Times Square billboard. And that saying that out loud seems kind of, but whatever, I'm grieving, you know. It's okay for me to want his face on the Times Square billboard. So I thought, well, I got to get NBC because they broadcast things on there. So I told Jason, you know, it was like from the 17th to the 31st, 13 days. And he was like, yes, absolutely. You can come up. You can do whatever you want to with social media, just whatever. And so you can go to the next slide. Oh, let me go back here real quick. I'm sorry. This is my badge at work. And the day that Jason reached out, his wife sent me a picture of his hat because I have my donor family badge on my badge at work. And Thomas's picture, I flip that thing over all the time to talk to people. And I just thought it was so special to see the other part of the pin, the donor heart. And he still wears his pin. And this is the actual pin. I took it off my badge to wear it in today. So you can go next. So on May the 30th, the day before Thomas's birthday, I had planned to leave. The plan completely fell apart. The person that was going to go with me couldn't. And I had the news people coming, had to deal with that. They did a story, but I didn't have, I was going to have to go by myself. And my best friend, Polly, her husband is Josh, and Josh is a liver recipient. He received his liver December the 31st, 2020, and it's a miracle that he lived. And they lost everything they had because he couldn't work. Everything. They lost their house, their cars. I gave them one of my cars. Their kids live with me. Like, so I've been through this on this side of it. And Josh went with me, and it turned out to be the best experience for him. Him and Jason bonded. And I mean, literally, he had Walmart bags. That's how last minute it was, standing by the road. You know, here I am. So we got up there. You can go to the next slide. May the 31st, Thomas's birthday. We got there. It was after midnight. And I had rented this place, and I didn't want to be there. I didn't. It was just, I just did not want to be there. But I stayed, and of course, the next morning on his birthday, here we go. I had to pretend. And I mean, I think that was normal. Nobody would just want to be there. I was excited to see Jason, but it was so heavy. This was Thomas's first birthday since he passed away. And we got there, we went on the porch. I don't think the news people were there yet. Oh yeah, I got the news to come there too. It's all recorded, this whole thing. And I was sitting there pretending to be okay. And you can go to the next slide. This is Eli, Jason's grandson. And Jason got up, we were sitting on the front porch, and he got up to walk in, and Eli started crawling after him. And I was just like, if it wasn't for Thomas, Eli would not have his granddad, you know? And I mean, that moment was a changing inside for me. It was. So it was so incredible. You can go to the next slide. I don't know what it is. Okay, this is a video. This is the NBC Nightly News 2003 Top 10 Good News Story. we've had several news stories broadcasted and 2 have been nominated for Emmys. 2. I found out about 3 weeks ago. So that's like crazy. It's exciting. We might make it to the Times Square billboard, but this is just a recap of the story. It's a video. Oh, it won't play? Okay, so I'm gonna do this. I'm gonna give y'all my website. It's terrible. I'm not trying to, plug stuff, but these videos are so moving. And it's www.longlivetom.com. So actually it's okay because they're sad. I mean, it's hard to watch. It really is. So next. So in this process, people ask me, why are you okay? Why are you okay? Why are you okay? Everybody asks me that because, it appears that I'm grieving great, I'm moving on. And I am, but it's just because I know how to grieve. I mean, I worked in hospice for 20 years and I mean, I'm prepared. I'm a licensed therapist. Like I'm prepared to grieve and I forced myself to do it the right way. But I wrote this down one night because it just sums it up. And this is what I tell people. A mother's love, wait, I can't read it. A mother's love continues to grow even after the death of a child. The trick is finding a place that your mama heart can be fulfilled. The decision to donate Thomas's organs not only saved the lives of his organ recipients, it saved me as well. And that's the truth. It is. Like I was thinking about it driving down here, what to say, because I've never prepared for these. And it's just the purpose of his life is so huge now. Like just being able to see Jason and his family, like we're family now. We cold call each other. Everybody's always says, do you get to talk to the recipient? I'm saying, yeah, we cold call each other. We're family. They're coming down in 3 weeks to spend a couple of weeks with us. But the next slide is a video as well, so it probably won't work either. Okay, this is another one that I want you to watch. This is part of our interview, and it wasn't part of the news broadcast. Jason's wife videoed it. I'm sorry. But it's me telling Jason why I'm so thankful he has Thomas's heart. That's like how I went from, yeah, I'm choking. I'm real. I don't try to pretend. I have a drink in my purse. Let me just grab it real quick. So there's a link to this as well on my YouTube from the website. You can go next. So Tom Manning, Forever 19. It's a beautiful story and I wanted to touch your heart. It's okay if it makes you sad, but see the beauty in it. I mean, this is the most incredible story and I can't believe that I'm living it. I mean, and I can say that on the heels of losing my child, but it's because of this organ donation, thank you. So does anybody have any questions or? I got my drink. Okay. Oh, that was on the video. I completely, so what made the news story so incredible is I was listening to Thomas's heartbeat the moment 20 years later to the minute he was born in another man's chest. I mean, I literally was. And I had a stethoscope. It's an Echo that it plays over Bluetooth over the phone. So, like we all got to hear the heartbeat and I just like, I can't describe. It's literally a new life with Thomas. It's a new beginning. I don't associate this organ donation, Jason, all of this with anything but joy. I do not associate it with Thomas's death. They are two completely different things for me. You know, because I found myself struggling with, I cannot feel so much joy about this and so much grief at the same time. Like, it's not consistent with each other. And, you know, ultimately I choose to live. You know, I chose to live after Thomas died. And so this right here is just the biggest purpose. And there's so many lives that are already changing from it. So many people send me messages and send me pictures of their organ donor signups. I get those all the time. I talk to mothers who've lost their children all the time. You know, so my purpose from this, I said from the beginning, it's to heal hearts. And I didn't know what that was going to look like, but now I do. And it's just a good journey. And I guarantee you, y'all will hear about Thomas Manning again. I can promise you.
We will share the billboard with this. group.
Yes, yes, it's gonna happen. It'll happen. Thank you.
I just want to jump back in one more second. To again, thank you for the space to allow us to have a presentation. I was actually talking with Cheryl a little bit on Saturday night, and it was amazing to hear the stories of the survivors and the people that were able to go home and live normal lives again. And we fully acknowledge that every time you have to pick up the phone and call LifeLink, it's not the outcome you're looking for. It's not the outcome anyone is looking for, but it happens. And so I think it's great to see people like Leah and know that although that is an end and an outcome that you didn't want, it's not always the end of the story, and that it goes on, and that it's important, not just for recipients. And many of you know I'm a recipient, so I can appreciate that as much as anyone. But for those donor families as well, how powerful it can be, even just to be offered the gift. Sometimes when donation's not an option, knowing that they've had the chance to vet that and to honor that their loved ones' wishes is truly amazing. So again, thank you as always for the space.
So Leah, we did have one question on the chat, Leah, for you. They just want to know if they can, if it's okay with you, how they can reach out to you.
Let's see, so I'm going to give you my email, but along with Tom, it's Tom's mom. Like, this is for real. I'm doing it.
You could just put it in the chat. I appreciate it. Thank you.
Thank you very much. That was amazing. Very, very heart touching. LifeLink's always been near and dear to my heart. I had a nephew that passed away many, many years ago, way before I even became a nurse, and was an organ donor. So it's very, very special. So I appreciate you coming. It was very nice. Thank you. Okay, Gina?
Push. Okay, push. I can do that. All right, afternoon all. Update, I know I wasn't even thinking about updating at this meeting. I'm so focused on tomorrow, but yes, tomorrow will be our big meeting for GQIP, so there will be a lot going on there. So that's our main update. We'll have a full day tomorrow. But the Arbormetrics project is the biggest thing. We kicked off officially December 22nd. The platform went live. Users started logging on January 5th, and everybody had logins by February 5th. And so tomorrow we'll actually be presenting some of the first data coming off of that. So we have calendar year 2021, 2022, and 2023 is all loaded into the site. So that will be exciting to be presenting some of that data in the closed session tomorrow to the group. Work groups, VTE, and time to care is what's on deck. VTE was supposed to meet last week and it got canceled, the first meeting. And we're still looking for a leader for Time to Care. So those have been a little bit challenging for that. The PSO, the Patient Safety Organization, will actually have a presentation from the attorney helping us draft that. Actually application went in. So we have our first meeting with the AHRQ next week for that process. So that will be exciting as well. To move forward with that process, and that will just give us some more protection as we work with the data coming out of Arbormetrics. So I think that's all. So, and I'm happy to entertain any questions.
So Gina, just for everybody's education, Arbormetrics is almost like a state database, like or state benchmark database. So we've got TQIP that a lot of centers send stuff to, but that's a national. And then we brought it together and we can focus more on Georgia information and comparisons and needs. But it'll be a little bit different. And that's what you were speaking to as far as the Patient Safety Organization, just making sure that we do it in a way that protects the information we have. Is that correct?
That is correct. So TQIP, our 1s, 2s, and 3s get to participate in TQIP through the ACS and its risk adjusted benchmarking. So there's not really anything out there for our level 4s, but with Arbormetrics, the level 4s will get to participate. And thank you for reminding me of something else. We'll be working on building our risk adjusted model for Arbormetrics. That's next on deck. So our level 4s are in Arbormetrics. So where TQIP will still have a place, Arbormetrics, because it only includes our state centers. So we're looking at just our state data, all of our centers within a state, and we get to do it a little bit quicker. So when we get data downloads on a quarterly basis, I send the data to Arbormetrics. And then once it gets loaded, usually takes 2 or 3 weeks. We make sure that, there's no hiccups there. It will show up in the platform. So it's a much quicker turnaround than what we wait for with our TQIP databases to see that data. So once we get on a good schedule with that, we'll be able to see it much quicker and hopefully be able to make changes and trend what we're seeing with our process and outcomes measures. So right now, what we have in Arbormetrics for our process measures, we have our hip fracture repair is in Arbormetrics, and also time to care. So we're looking at our transfers in and our transfers out within Arbormetrics. And then our outcomes measures, we have mortality, and we also have some of our hospital events. We have AKI, unplanned return to OR, unplanned ICU admits, surgical site infections, and CAUTIs are what's in there right now. And our next process measure that we're going to start working on is VTE prophylaxis, which will be in the system.
That'll be great. And when we talk about risk adjustment, for those that don't understand it or maybe are newer, that TQIP takes certain things like a person's age. So a 63-year-old person like myself, if I was in a car wreck versus, a 20-year-old, the 20-year-old would probably be assumed to have a better outcome because they're younger, they're more resilient, they have more physiologic reserve than I do because I keep having surgery. But, you think of things like that, or maybe I've got a history of high blood pressure or things like that that affect how well patients respond to injury and to treatment. And so while TQIP kind of tells you some of the things that they use, they don't really tell you how they weight them. And so sometimes it's a little frustrating because their reports will say, well, you had this many deaths. Say you had 100 deaths in this report, and this is how many we expected to die, and this is how many actually died. So sometimes you can make sense of the data. You would expect older people or people that are sicker to die, but you want to understand it enough that, well, how can that inform your thinking about the care we give, whether it's the timeliness of the care or the type of care that you deliver or the system of care when we're talking about time to definitive care. Maybe starting at a smaller hospital, but they need a surgery that's only available at a level 1. So, getting them there timely. So I think this is really exciting. There are only a few states in the country that do this. So we're kind of cutting edge, and Gina's helping lead the way. We're all bumbling through it, but we're getting there, and that's a positive, and that we can understand our data a little bit better and maybe get to a understanding of what's going on a state level, because it does make a difference, because of what or how we work in Georgia is going to be different than Florida or Mississippi or whatever. And we're going to have our own little nuances that make a difference as far as the distances, how many trauma centers we have. It's very positive. We've got a new level 2, Phoebe, welcome to the system. So we have those, we're adding the care, so that people don't have to travel as far. So I think it's going to be really exciting in the next couple of years to see what happens.
Great.
All right, I guess we'll move on to our subcommittee chair reports. Kendra?
Good morning or good afternoon, everybody. So the Education Subcommittee is working on two major goals this year. I'm going to back up a little bit. We're working on two major goals this year. The first one is to develop a toolkit for trauma program managers, specifically with the intent of trying to help new program managers at centers throughout the state. And we're actually dividing the information into level 1, level 2, level 3, level 4s, so that the new managers throughout the system will have a sort of a comprehensive toolkit to help them navigate that first learning curve where you're just drinking from a fire hose. You're just trying to survive and learn the things that you have to do. So we've got it just about ready for the first pass for everybody to look at and start tearing apart and checking all of the hyperlinks and making sure everything works. I had wanted to have it done for today, but life happened and we just weren't able to get it complete for today, but we're probably about 85% of the way there. And I'm hoping to have that complete by our June education meeting. We'll send that around throughout the education committee, get feedback, and then I'll send it to the leaders in GCTE for feedback before we then release it. It's got everything from, contacts at the state, contacts at other level 1 centers. If you're a level 1 new program manager, contacts at level 2 centers throughout the system, so that you will be able to reach out to people who know exactly the types of information and reports and the programs and things that you need for your specific center, as well as some information about, your TQIP reports, about GQIP, about our state meetings. Really, we're trying to make it as comprehensive as possible without making it a 4,000-page document. We're really trying to embed as much information and at least send people then to where they need to be to get the more complete set of information. But at least it's where do I start? That's our goal. So we're just about, that should be done by the June meeting. That's my goal. The second main program that we've been working on this year is trying to help develop some. It started off with the idea of being essential skills for nurses in non-trauma centers that we felt like they needed to have and needed to know when they were caring for trauma patients in that early pre-transfer period to a trauma center. And it's actually kind of transitioned now to being more of an information poster that we've envisioned of what are the things that really are priorities for non-trauma centers? What do they need to know so that they are able and best positioned to provide the safest, most efficient, most effective care for seriously injured trauma patients and help speed up the process to get them out the door to definitive care. Gina, that time to transfer, really trying to focus on that. So Keith Dawson down in Savannah has been helping to lead that part of the project. He's been fantastic at it. So I think we'll have something ready to show also at our June education meeting. And then hopefully we can get that out also for feedback and review. So the only other thing that I wanted to mention about, and I do apologize, I scooted right in here at the very ragged edge of disaster starting with this meeting. So I didn't get a chance to check with Tracy or Cheryl about trying to use the Georgia Trauma Foundation calendar as an information repository so that we can load information about classes and, this trauma program manager toolkit and the posters and all of the information for the great work that's going on around the state, trying to use that as a sort of a master repository for the trauma centers around the state. And do we have any more information about that? Sorry.
You will be able to do it one of two ways. We're just making a decision on now which way it will be. You'll either have an entirely separate website where all the information will be housed and we would take care of that, or you'll be able to access it through our website. So we're just finalizing those details now.
Great, thank you. For those of you who are online, I'm not sure if Cheryl's report, you were able to hear it, but she basically says that they're really finalizing right now. It's kind of there will be one of two ways that we'll have this website available. It'll either be a separate website that will direct people to, or it will be a way that you can log in a secure way to the Georgia Trauma Foundation's current website. And they're just kind of finalizing that, and we'll know more soon. So thank you.
Thank you for bringing that up, Kendra, because that is, something we've had before. Cheryl and I had talked about it and worked on it a little bit, but like you said, life happens. She had the Porsche experience coming up in that grant. And for those of you that don't know, the reason I'm not there today is because I had my gallbladder taken out Saturday night. And so at least they kept it as a laparoscopic procedure, but I'm not ready to tap dance up to Brazelton. So I'm sitting in my recliner and recovering from gallbladder surgery. And so, that's part of life and that's what gets in the way. But, Dr. Ashley says I'm now on surgery restriction. I can't have any more surgery. So I will try to beat that off. But thank you, Kendra, for your report.
Haley, next.
Hey, everyone. Gonna give just a short update on the pediatric subcommittee. All of the SIPA information went out, and I'm happy to say we've had a couple of centers reach out and ask for additional education, so that makes me very happy. To parallel with the education subcommittee, our group is also looking at timely transfers and pediatric transfer rationale. We are in the process of creating an interfacility transfer toolkit for pediatric patients. We have the different sections of the toolkit. We're in the beginning stages, but they've been assigned. So our next meeting is in May, and hopefully we'll have some rough drafts of some of those sections. It's pretty exciting. CHOA is starting the MATIC-2 study in September, which is whole blood. So as soon as we start that study and it seems like whole blood is safe for pediatric patients, then I'm sure our work will be cut out for us to do education around the state and get kids on the whole blood bandwagon, which is what we're hoping to do.
And Kelly, if there are people out there that would like to be part of your group or Kendra's group, I know we've got a couple of new program specialists, but if you'll look up on your GCTE contact list, wouldn't they just be able to contact you, Kelly, or Kendra, and just drop you a quick email to say, please invite me for the next meeting? And then they can get invited to the meetings or know when they're happening, right?
Yes.
Okay.
The pediatric subcommittee is very tiny, so. But dedicated, yes.
Yes. And
Right.
that's true for any of these committees. You can contact that committee chair and they'll let you know or put you on the invite list for their meetings. Sorry, Lynn.
Oh, you're good. Process improvement, Raymond?
We kind of rebooted our committee in March. Myself and Ashley Bullington are chairing together. We're still working on time to definitive care. We discussed a lot about times because we've never really put a time around it. And I think that's everybody's biggest struggle is what time should that be? We have a survey that went out. We'll be discussing on May 28th, our next meeting. So we'll be discussing what came in on that survey. Also ask for what are your barriers? Because sometimes that's your biggest thing right there is your barriers and how then we can maybe focus on those and get that moving, help people to kind of break down those barriers. A little bit of discussion on using the registry to capture what we're doing. Not a lot of us from the survey of what I saw are using the registry to be able to pull that data back out. So that may be something that we'll work on as well to see how we can use that to show us where we're at with all that. And then our other thing was we're still analyzing the lit review. So we'll utilize that once that's all put together on where that leads us as well. So that's it.
Thank you. Kelly had to step out. Crystal Smith, are you on the line for your injury prevention?
I am. Can everybody hear me okay?
We can.
I do have some screens, so if I could share them, that would be great. So just a few reminders. I kind of preloaded my report in your chat for those of you that are on the chat. We did do the badge buddies for April. That was the Prevent Child Abuse badge buddies. We also did badge buddies for the Blue campaign. If anybody would like the template we used or even the badge buddies themselves, they can reach out to me. But if you want to, co-brand them or kind of make them your own, please feel free to reach out and I'll be happy to send that to y'all. I just wanted to remind everybody that this week, in addition to being all the other things that are being celebrated this week, is National Stop the Bleed Day, falls this Thursday, and we are going to be doing our Georgia Trauma System webinars. That's going to be again this Thursday. We do have plenty of, it's fully staffed now. I want to thank all of y'all that are looking out after me. I didn't actually have to do a call for help. Actually, when I posted the event, several of you contacted me, and so we are fully staffed for those webinars. And it's kind of a different team each time for those of you that haven't been a part of those and you would like to be a part of them in the future. You want to see how it runs, feel free to log in. We're actually going to have multiple sessions, a session at 10 a.m., 1 p.m., and 4 p.m. I just kind of wanted to share with everybody just to make sure we all know that this is for all of us. My contact list for this program has grown to around 7,000 folks, but I certainly can't get the emails out to everybody as quickly as I would like. Apparently there's limits on emails. So feel free to co-brand that flyer that was sent out if you would like. Send it out and invite the folks in your community. It is free. It's open to the community. And just to let you know the scope of work with the various webinars that we did together last year, we had about 1,500 participants. The one this week is the smallest one just because it's only one day. And certainly the one that will be coming up in the fall for back to school is our largest one, but folks really enjoy it. And we do get the county level data at the end of the presentation, but this is what we have so far in terms of registration just for this particular one that's coming up. So just for this Thursday's webinars, we currently have about 250 folks that are registered. To make registration kind of very simple for folks, they can register multiple folks with one ticket. So some of these sites that you see here represents perhaps a team of folks sitting in together to watch the webinars. Also, if anybody would like to help, I know Lynn and we kind of tag team a lot of the door prizes for these. This is kind of our secret sauce to keep people engaged in these webinars and paying attention. For those of you that know, you know, but we do these Prevent Trauma Llama t-shirts. And so if anybody would be interested in helping send out some door prizes, or maybe we're willing, it costs about, $25 to kind of drop ship a Prevent Trauma Llama t-shirt to a course participant. So if you'd like to help with any of the door prizes, again, we would appreciate your help. I know Lynn mails a lot of these, and so she would definitely appreciate some drop shipping. So you can call me, you can email me, you can find the event itself at stopthebleedgeorgia.org. In the chat, I went ahead and added some other things for you as well. So again, the Child Abuse Prevention Badge Buddies are still available. Let me know if you would like the template or the Badge Buddies themselves. The Stop the Bleed webinars are again Thursday, and the registration link is there. Also put in there for the Prevent Trauma Llama t-shirts. I know some of y'all have asked, how could you buy them for yourself or maybe buy them for a teammate as gifts? And so we just made it really easy. You can go and purchase them yourself. We don't keep a stock of those because we do obviously run through them very, very, very quickly. I did also just want to extend an invite for next week, also in celebration of Trauma Awareness Month. I know many of you are very, very busy, but we will have one of our MCI Multiverse exercises. If you haven't participated in that and you would just kind of like to see what it is, you're welcome to. Maybe talk amongst yourselves, those folks in the room that have participated, and let folks know that it's relatively painless. We would love to have more folks join in those if they would. And then finally, coming up in June is our Georgia Stay Safe Week. That's June 16th through the 22nd. It's really about firearm injury prevention in children, specifically about, kind of working with parents and caregivers to make sure those firearms are secured in the home, especially as children are visiting with friends and family members this summer. So that activity guide and communication guide can be found at georgiastaysafe.org. And then I think that's pretty much all I have, Lynn and Tracy, other than a couple of y'all were expecting some materials for bingo size and also some bleeding control trainers, stuff like that. Josie graciously traveled up today with those items. So if y'all would touch base with Josie, she has those things that were needing to be delivered today.
Josie, you want to raise your hand so everybody know what you, she's that little girl in the front. All right. Kelly had to step out. She'll be back, so we'll skip over her. So thank y'all for all your reports. I try to call into your meetings. Y'all are a very, very busy group of individuals. Lots of great work though. I really appreciate it, especially for our smaller centers to kind of tag on to y'all for everything you're doing. So great job. I appreciate everything y'all do. So I guess we'll move on to the standards review. We'll get Kelly when she comes back from her meeting. Yeah. That's, we can skip that one. Okay. So the first thing we want to look at was our alcohol misuse screening. So Tracy just asked me to talk about what we do at Fairview. We are a level 3 trauma center. And there's a next slide, I think, on that for that one. The next one, maybe. There we go. So this just explains what the standard is that all trauma centers must screen on all admitted trauma patients greater than 12 years of age for alcohol misuse with a validated tool or routine blood content testing, and you have to have a screening rate of 80% or greater. So we are level 3, so we're very small. So what we do, how we perform this standard is every day our trauma PR coordinator, when he does our list to see if our patients and for our register inclusion, he sends a daily admission report to our case manager, social workers, and then they go and they perform we use the audit tool. We don't have the routine blood content testing. But they go to these admitted patients, and we use the audit tool for patients greater than or equal to 18 years old. And then we use the CRAFT for our patients 12 to 17. And that's just two images there below what those two are. And then the next standard, the 5.31 is the intervention. So at least 80% of the patients that screen positive, you must give a brief intervention by appropriately trained staff prior to discharge, and it must be documented. So our social workers, they provide this intervention and referral. And I just added what the definition for the brief intervention is. We have a little one-pager sheet that we give out to the patients that explains the risk and the behavior changes that they can do, and also a referral, what's in our community or what the community they may be from, what's around that they can go and seek out help. And if they need treatment, then they're referred to the specialty care. And then the next slide is just showing how we report that out. Is the documentation, how many inpatients were screened, the percentage, and then the positive screening with interventions. So I know there's a lot, multiple different ways to do this. The only thing we struggle is, of course, it's just me and my PI coordinator, and he doesn't work on the weekend, so we miss those weekend admits. If they come in on a Friday, then the discharge on Sunday, then we miss those. So but that's, we have 80%, so that's, we squeak by, but of course we want to capture all of our patients that are admitted. So we are working on an automated process for when patients are admitted, that the social workers and case management, they get the automated email showing that this patient they could be a possibly trauma patient. Because of course our trauma surgeons are also our general surgeons, so we, they admit much more than just trauma. So we're working on that. But that's just the way that we do it. And Tracy wanted me to share it. So any questions on that? I know there's multiple different ways to do this. Okay.
I really appreciate you presenting, Lynn, because, there are a lot of ways to do it. And you kind of have to make do for what works for your hospital. I think I shared at our last meeting, in 3 surveys, I've only missed one standard, and it's been SBIRT, and both times it's mainly because of staffing. We'd kind of established a way to get it done, but we just didn't have it. So for us, because we've got more volume, it takes more than just, we've got to have somebody to do it and oversee it. But, there are a lot of ways to get it done, and I appreciate you sharing that. Before we hear from the next person, I wanted to recognize some stuff that's already been mentioned, but it requires more than a mention. We want to congratulate Grady on their successful survey that they had in March. Kennestone, who surveyed and are moving, I don't know, Jamie, if you've gotten your actual letter yet, but they surveyed as a level 1. And so, just going through that. And then also our newest center, level 2, is Phoebe. Are there any other successes or celebrations that we want to share?
Effingham was redesignated as a level 4 facility.
Woohoo! I think all redesignations, surveys, I don't care what you say, and every time Dr. Ashley will tell me, don't sweat it, don't get upset. If I'm not upset about it, you don't need to be upset about it, which is like, yeah, right. So, as no matter what you do in the program, you want to do your best on a survey and a whatever, but it's always stressful, but it's a good feeling to get through it. And you learn about your program and you learn about yourself and your teammates. But I didn't want to go by without recognizing that, and I appreciate being reminded that we needed to do that. Our next person that's going to talk to us is Sam Buchanan. And one of the things I asked is when I talked to Jamie and Sam about what's something that you've done, and can you share just something about your survey? What went well, what was troublesome, where you feel like you crushed it. I mean, what was something that you wanted to present? And so Sam is going to present the Reader's Digest version of what she'll go over tomorrow in a little more detail. And it's related to this standard 415 about interventional radiology. It's really just for level 1s and 2s and the pediatric and adult side, being able to go in and stop the bleed when you have to do it vascular wise. And so this was something that they really had to work on to get corrected for their survey. And so it's always nice to kind of hear what other people do. You might not be able to do it the way she did it, but it will give you ideas and also give us a chance to meet Sam.
Thank you so much, Tracy, for that introduction. And thank you for the shout out too. We're happy to be on the other side of our survey. So my name's Samantha Buchanan. Like Tracy said, I am the interim trauma PIPS manager at Grady. And so like she just mentioned, I'm sure all of the level 1s and 2s are very familiar with the standard by now, 4.15. This just essentially says that you've got to have the people and resources available 365, 7 days a week, 24 hours a day. So when the new standards dropped in late 2022, we already knew that we were going to have a challenge on our hands. So we actually, during our site visit, our process was cited as being a strength. So we're very proud of the work that went into this. It was not easy. It was a huge lift. So I can share a little bit about that. Like she said, I'll be presenting in the best practice session tomorrow as well. But next slide. Okay, so obviously, like I said, the challenge was our times were way too long. So looking back at 2022, we had a total of 110 IR cases, and our median total turnaround time was over 2 hours. Only 4% of those cases would have fallen within the 60-minute window. So obviously, we had our work cut out for us. We came together as a team. We formed a multidisciplinary task force again at the end of 2022 when these standards dropped to kind of figure out what can we do to attack this and be successful. So we identified some opportunities. We had a lack of efficient coordination across different care areas that touch these IR patients. Obviously, communication is always an opportunity. We needed more resources to be able to carry out these procedures safely and efficiently. And then the biggest things for us were we lacked a process. We didn't have a standardized process, and we didn't have activation criteria. So those were the things that we kind of came together and said we needed to focus on. And so some of the solutions, this is a long list. Again, we formed that task force. It's the STAT IR committee. Our TMD, Dr. Benjamin, revised our IR trauma guideline. And in that guideline, it had specific trigger criteria for which cases we were going to consider to be in the STAT IR bucket. Additionally, we partnered with our EPIC team members and we created a STAT IR consult order. And so that is separate from the routine IR consult order that goes in. And so this is specifically for those cases that meet that trigger criteria. We also, I'll show you in just a moment, we standardized our notification process from start to finish as well so that everybody would be aware of what you needed to do when we activated the pathway, and that is in our guideline as well. The next thing we did, this was huge from an accountability standpoint, we meet every 2 weeks to review our cases, and it's the entire committee that comes together to review these cases. And so during our 2023 data collection year, we met in person. We didn't even give a virtual option because we wanted that engagement and that accountability. And we still continue to meet and review these cases. We also, when we broke down the process, we measured times in each phase of care and kind of assigned target times. So like if while the patient was in the MTC, which is the Marcus Trauma Center, that's our trauma specific ED, we want that team to be able to get the patient ready and up to IR within a 20-minute window. Once the patient rolls into IR, we want them sticking within 25 minutes. So we tried to break it down into chunks and see where our opportunities were in order to realistically meet the 60 minutes. Another thing that's been huge for us is the trauma RN from the MTC goes up to IR with the patient and they stay there in IR so they can be an extra set of hands if needed. We partnered with respiratory therapy and their administration to get a transport vent that lives in IR now. So that's been helpful to prevent those delays. Anesthesia, the anesthesia techs have added IR to their area checklist for 24/7 readiness. So they treat it just like the trauma room. The IR tech is still coming in after hours, and so they cross-trained in-house radiology staff to kind of step in and help facilitate the process while the tech is driving in if needed. We also focused on documentation for the trauma nurses in the ED. We want them documenting each key phase of the process with time so that it's easier for us to go back and audit these charts. We also focused on earlier groin prep. So we want them clipping their groin while the patient is still in the trauma bay, if possible. It saves time once they get upstairs to IR. This has been a luxury for us. Obviously, not everybody has this resource, but they were able to get the IR nurse coverage 24/7 in-house. That it was not the case initially. They were having to be called in after hours as well, but now they are in-house 24/7. And then lastly, we revised our guideline even further at the end of 2023 with specific notification criteria for anesthesia. Next slide. It's a lot, sorry, y'all. So this is just a picture of the reference tool that I created, and it's small for those of you in the room, but it just shows you how we broke down the process from start to finish, the target times we assigned to each phase of care, and it's got our trigger criteria at the bottom. So this was a tool that was disseminated to all of the staff. And so this is just a quick reference for them to see the why behind why we were focusing on this. Next slide. I'm happy to share any of these resources too. Yeah. Okay, and so how did we do in 2023 or in our data collection year? We put our money where our mouths were. So this just shows you where we started at the beginning of the year and where we ended at the end of the year. So with our median turnaround times, we saw a 51% decrease overall. So in December of 23, we were down to about 44 minutes for our median turnaround times. And then the slide is kind of cut off, but you can see on the right-hand side from a monthly compliance standpoint, this is what the site reviewers want to see, right? You have to be 80% compliant. And so it shows we became compliant over a very short period of time. We were cruising, doing a really great job. And then unfortunately, we dipped right below in December. We hit 78%, which was a huge bummer and it was concerning. And we were like, well, how are the site reviewers going to look at us seeing this? Again, they cited our process as a strength because overall we were able to prove that we were able to improve our processes. And so next slide. This is the last slide. And then this just shows you where we are for 2024 so far. Unfortunately, in January, we fell even further. We were at 67%. IR was going through some leadership changes at the time. And so we kind of, attributed it to that a little bit, but obviously focused on some other opportunities as well. And then we're happy to show that February, March, and April, we've been 100% compliant. So it kind of shows how even in your PI processes, you feel like you're succeeding. There are ebbs and flows. So we had opportunities, we were able to overcome that. And so how do we sustain this change? Again, we're still reviewing these cases in a concurrent fashion. Our TMD, Dr. Benjamin, I really like this. She equated the entire process to a relay race. We're passing the baton from one phase of care to the next. And you have to rely on your teammates to be able to get that baton to you. And if you stumble any way along the process, then it's going to eat up time and you might not meet that 60-minute target. So that's been a nice little mindset for us. Obviously, we partner with all of these departments that take care of these patients. We want to recognize successes too. So something huge for us, the MTC documentation piece for those nurses, I make sure to send their leadership shout outs when they're doing a great job with their documentation, because that's been huge and it makes my life easier when I'm auditing these cases. We report out on all of this monthly in our operations meeting. Again, we have that pathway tool that I created for the frontline staff. We have ongoing education, and then this has been big for us too, prioritization of life versus limb. Earlier on, we were seeing delays with cases where, say, it's a polytrauma, ortho wants to come in and throw in a traction pin. that has delayed us previously. And so we all came together, had a meeting, TMD, ortho liaison, and really said like, the purpose of this is life-saving, it's hemorrhage control. And so I know that you guys need to come in and you need to do your interventions as well. Unfortunately, IR takes precedent. So you either get it done in the time frame or you can come upstairs with us to IR, but they've been on board with us. We got a lot of buy-in, so this has helped us a lot. IR continues to analyze their staffing. We have a 30-minute callback window for the tech and the physicians. We have not had any issues with that, thankfully. And then this may sound silly, but the whole relay race mindset, it kind of feeds into the competitive nature of those of us in healthcare. We have timers if the staff wanted, just so that they could have awareness of where they were on the clock. You don't have to use it, but it was there if they wanted it. And then unfortunately, or fortunately for them, the IR physicians are Emory, and so they cover call at Emory facilities as well. And so there are talks, we've had some delays where they might be covering at another facility when we need them at Grady. And so they may be looking at creating a specific call pool specific for Grady. So we'll see how that goes. And then from a registry PI standpoint, we created some custom fields in the registry, and we've added an additional secondary meeting as well. So again, it's a lot of work went into this, so I'm happy to share any of these resources with anybody that's interested. And that's all I got. Thank you so much. Any questions? Thank you. No? Okay, thanks.
All right. Thank you so much for that. Kelly's back, so we'll get her registry update.
Yeah, so I apologize, y'all. I had a 1:30 that I had to do. So the registry, I'm going to start with the simple things first. So just as a reminder, in February, we completed the Trauma Registrar AIS course for 2008 for people who were either wanting to take it as a refresher before taking the CAISS exam, or for those who had never had it. So we did that. Of those, I have 5 who took the course, took the March 2024 exam and passed. And then 5 from 5 additional centers are planning to take the September 2024 exam. So I think we ended up with close to 30 people taking that course. Some were PI coordinators, some were just trauma program managers trying to understand. But of those who were taking it for the registry piece of that, they are moving forward to the next steps, which I think is great. So from there, we are looking at asking the commission to host an AIS 2015 course, a virtual update in FY 2025. The ask will be for 60 participants. It's virtual, so it's not in person. And the cost is $380 each. So we're looking at asking for $22,800 for 60 people. So be looking for that to come tomorrow towards the Georgia Trauma Commission. So there's that piece. Registrar education, for those of you who are new to the GTC, the Trauma Commission contract deliverables, there is a deliverable in there now for levels 1, 2, and 3 that include TQIP, the TQIP continuing education requirement, and attendance or participation in 50% of the monthly education experiences. So if you're not tracking that now, that is something that's coming forward. We talked about that in our meeting. And as trauma program managers, if you haven't reviewed those contract deliverables, that's something you may want to just make sure you're on top of. The last thing to talk about, which has probably created a little bit of trouble over the last couple of weeks, is the 2024 ESO patch. So for those of you who are on ESO, if you've not had your ESO patch, be prepared. There are a few little glitches. If you have had the patch, we're going to go over some things that you may have seen and how we are being asked to address this. So I've got an email that should have gone out to everyone Friday, Gina, wasn't it Friday? Or the 17th? It was the 17th. I think that's Friday. All right, so basically, in ESO, we were asking for them to update V5 so that we could include the LifeLink organ donation fields. We were also asking them to update a couple of the EMS fields so that they could transition over. Gina, feel free to interrupt me if I screw this up. So when the patch was installed, for whatever reason, the death questions now, we thought when we asked for this death piece, that the registrars would only have to go in and update those patients who died since January. Well, it seems that it doesn't matter if the patient died or is alive, it's asking you to validate. Now, their response, according to the email, if you've read the email, it says this is a bug and it's being sent back for resolution. They do not have a timeline as of yet, but they're pushing for a quick turnaround. As of now, they're asking you to go in, and when you click validate, just keep clicking through. Even if the patient says alive, we know the patient is alive. If it's asking you to respond, just click validate and it'll work you through that patient, correct? I'm making sure.
Yes. But there are popping up a lot of validation rules that are not supposed to be in the update.
Mhm.
So I'm just gonna put that out there. All these valid things should not have to be validated. So, I've not heard from them today. So that's where we're at. So they know that they have a lot to fix.
The
We don't even
EMS
have a summary of what was in the patch that they submitted. So there's a lot of issues right now. So what I can tell you is that I am communicating with them and passing everything that we receive. And I will tell you that they communicate a lot with me because of the GQuip Central site being an ESO site. So a lot of things they will email me and Marie, both. And so there's, if you have an issue that you find a glitch, you might want to send it to me, because I don't have a problem taking it up the chain very quickly because I have that connection. So when you find an error that comes through with your registry, please send it to me because I don't have a problem taking it right up. So, I was on the phone late Friday, with them. So they have promised me that they will get this fixed. And I will tell you, part of the problem is that V5 is kind of broken. And I don't know if any of y'all have ever had any legacy products that are sundowning, like an EMR or anything that's just old and they've band-aided and duct taped it together. That's the best thing that I can kind of liken what V5 is right now. They don't have a lot of engineers that really understand how to work on it. And so it makes it even more difficult. So when something breaks on it, because I really even said, I almost don't want to touch it at this point. It's because you do one thing and it breaks 10 things. Have you ever done anything? I kind of feel like that's where we're at with V5, which is why part of the reason that I have learned that the whole new registry was created is because V5 is so friable because it's such an old product. Because technology has moved. I mean, I think if we realize, those of us that have been around for as long as we have, V5 we've had for almost 20 years.
20 years.
And when you think about technology, 20 years is a really long time for software. So V5 is more than 20 years old. So that's why it keeps breaking. And now it's hard to put it back together. So, it's kind of like duct tape and bubble gum now, and the technology has come so far, it's kind of hard to kind of engineer it together. So that's the best I can liken it to. So, and one little glitch you make, it kind of becomes a cascade effect. They fix something but it may break three other things. And I think that's kind of where we're at. We thought, I almost said, I wish we hadn't have, and I know Tracy, don't shoot me for saying this because I know this was something that we wanted. We wanted the organ donation fields, but I think it broke a lot of things when we added it, so we're going to work through how we can best fix this. So, and try to get our download done timely. So what you need to know is hopefully your TQIP download is still due June 3rd.
June 3rd.
Okay. And this should not affect that. So we will work through how this is going to affect your OEMS&T download and GQuip download. Because this patch you needed to do both, but you didn't need it to do your TQuip download for the 1, 2s, and 3s.
So there's an outcomes tab problem or issue that was noted. And apparently when you try to validate, the pre-hospital comes up with fields that it says you need to work through, which we did not ask for. And it's okay if you don't have information in, you just click through to validate process.
Yeah. So
Just to click it.
there's a lot. And I don't think we've even found all the issues that the patch caused. So just have some patience. We're trying to figure it out. But if you find something that you locate within the registry, please just send it to me, even if I already know it's great, because I don't think, I literally told them on Friday, I told Garrett Hall that it's almost been like an Easter egg hunt because we don't even know what was in this patch now.
And Gina, hey, this is Tracy.
Yes,
I appreciate you saying the thing about me wanting it because we did.
we did.
In the case of, creating so many other issues, at this point, I would be okay with us, backing it out, but I don't know if we can.
I did ask that question. It might be possible to undo the patch that was mentioned in the brief conversation I had late Friday. Could we just take it back to where we were?
Well,
and that may be a
just leave it
possibility.
alone.
I have not heard back from them yet, but that could be on the table that we just undo it.
Well,
So-
so for those who have not had a patch, they need to stand by.
Yeah.
That would be my recommendation.
Yeah, if you haven't installed it yet, you might want to pause.
The other thing I am concerned about though, Gina, is, we're getting ready to have to make a big move in that they're sunsetting this software. So we've got to go somewhere with it. But I'm concerned that they give us a patch, but they don't even give us a list of what they're quote fixing.
The
So-
summary. Yeah.
Right. So some of those basics, to me, that's just basic good practice. And if they can't keep that up, and then they had the incident earlier last year where, they had a data breach and the communication was not very good. And this, affected a lot of hospitals like Kennestone and Grady trying to get ready for finish up their data year and get their data ready. It was just not a good scene. And so I understand that they don't have a lot of engineers that understand V5, but they still got a lot of people on V5. So, for us to have to make a decision of where to go, I think customer service and communication needs to really be emphasized. Because I would say I don't have I'm not married to the ESO product just because I'm so turned off by some of these lack of, just goodwill, good faith, good communication and transparency on what's happened. And I know that there are a lot of things playing into that, but they need to pick up the game because this is our life. We're the end user and they need to please us. So
Well, I will assure you that I go to bat, for the state, the centers, the registrars, anything that causes an extra keystroke, a button push for the registrars. I say like, no, like when they have said, well, they'll just have to, all they have to do is click validate. Like, no, like if it's extra, like that's extra work. They're already spread thin. I will tell you that part of this, push was the update was late. And you have to understand part of that, like it breaks the whole Arbormetrics project when our data is late. So this update was supposed to be around March, and then it got promised to be April, and then it was the last of April, and then suddenly it was the middle of May, and that's when Gina kind of threw the red flag. So I think the lack of us having a summary document was me running it up the chain and saying you need to expedite getting this out to us, which they did. But I think they dropped the ball with some of that and trying to get it out and installed, so we didn't delay our update a little bit.
I
So
don't
there
think
has-
you're
there has-
responsible. They're the ones
No,
who
no, no.
promised a date and didn't make it. So them being late is not your fault
No.
for them not having a summary document. Because to me, that would be something that you're working on as you're updating your software. Just like we have kind of a game plan, or Sam showed in her slides, they're kind of, this is where they broke it up in time periods, and this is where they needed to be when, so I just am real, I have a lot of trepidation in them promising us stuff and delivering when they say they will, because over and over again, we're not seeing that happen. So, I just want, maybe you can convey that. And maybe it's because it's the V5 and it's, they don't have a lot of engineers on it, but they still need to make good on their promise and on their reputation and their name.
Yeah, I agree. But I
So-
will say, like, we, right now, we have to stick to the registry we are on. For the 3 years we are committed to Arbormetrics, because it will break that project, because we are, the way we have set up Arbormetrics is we are an aggregate data project, meaning we send our data to Arbormetrics in aggregate. So we have to have a central site, and the data has to be formatted the same way, and then sent to Arbormetrics. So
Right. So
we can't.
Once the data gets to you, it's in a set thing. So you have to stay on it. But what happens to the centers who decide they don't want to go to ESO? And which I'm understanding that maybe HCA has chosen a different software or even building their own. And then how does that affect your trauma commission contract? Because right now that's what's in there, saying you have to be on that product. But I'm all, I don't want to mess with Arbormetrics because we're getting it to work. We're starting to hum, but I'm talking mostly from the facility standpoint, that they're not, we just need to kind of take a stance in wanting a quality product and making sure that they deliver to us, and us not settling for being late or this or that, that kind of stuff. So I'm not trying to ruin your life and change Arbormetrics, because you'd probably have a nervous breakdown. So I don't want to do that.
Can't. I mean, it
Yeah.
can't, we can't accept data from any other platform, and that's where that stands.
Okay.
I guess, Gina, will this impact any of our TQuip downloads though?
Because I think that we do need to consider, but I understand we made a commitment to arborimetrics, but as a requirement for our ACS, TQIP is, we have to do that. So are these things going to impact our ability to be timely with our TQIP submissions?
What
This mess going on with
The
VFAS?
patches.
it shouldn't.
Okay.
Well,
And my
this
other
is my question. This is
Oh,
what I don't understand because I
yes.
think you have to go back and validate every record. And so for the larger centers, I think it's gonna be a matter of to close it out so that then it can submit. That's my concern.
I don't
for our-
think, I don't think has anybody done their TQIP download since they got their patch? I
Yes,
see a head
who said
shaking back
yes?
there that Jamie Van Ness has done
Yeah.
that. All right. The other question I have, just you guys may know this more than I do. We didn't even start our download because this got caught or our upgrade whatnot. So I hear you saying don't do anything, but are we going to be late then for our TQIP upload, or can we submit what we have? I think
Have you not installed?
we have not.
Then you can do yours.
Okay.
Yeah.
So we don't need to do anything
You don't
right
need to-
now
yeah.
until, okay.
This is only your state. This patch was only needed for your
Correct.
state.
TQIP
and
did not
GQIP.
make any changes.
Yes, you
So the
already had
patch-
your TQIP
Okay.
update.
So you're
Just don't touch
golden.
it.
You're
Don't
golden.
touch
Just
it.
don't touch it.
Just
Okay.
Don't touch it.
Just
That's where, in
Yeah.
summary, where I was going with all of this is for those of you who have not done your patch, at this point, I would hold off, honestly.
Yeah.
That's an interesting concept. We need to hear more about what happened there.
And I will make a phone call as soon as we get done.
So the people on the phone can hear what Jamie says. So Jamie says she downloaded her TQuick report and it came out with lots of validation errors and it did not submit, correct?
And it did not tell her why or how. Like, there's no information with the errors, correct?
Correct.
Yes,
That's okay.
it's okay.
Feel like I'm in limbo. If it is that we can back out from this, is that something that can become a priority and we get it passed back out and we still keep our dates and something on time? Is that an option? And if that's an option, could we really work on that one so that we can get that piece done?
I said, as soon as we finish this up, or as soon as we finish this discussion, I will go make it.
Because I think now that we know
Yeah.
that someone has tried to go to
Yeah,
TQIP
'cause
and
we didn't
there's been a
have- I mean,
problem.
like literally, this just started last Thursday.
Yes.
So like,
Now that we know that, we can push ESO even more to try to back it out because that seems to be the logical solution. Honestly.
Yeah.
So I apologize for those of you that wanted the LifeLink organ donation information. That may have to wait. We're backing it out.
Way to go, Kim.
Not to get lost in all the ESO discussion, Kelly, I'm glad that we've got this presentation or ask for the education for the 15. Because starting with 25 admissions, we've got to use AIS 15 coding, correct?
Correct.
So this would help kind of offset, it's not going to pay for all the registrars in the state, but it would help offset. We would want to give a chance for the smaller centers, who don't have as much budget to get some people in there, but also share the love with the other centers and get people trained. It's only, I think, a 4-hour online course. Is that right?
That is correct.
Okay, I'll try this one. Oh,
I just want to say also that wherever we go from here, we'd be happy to be a part of the conversation because I think that there are some things that are sort of burdensome when it comes to the registry related to donation. And I don't know, honestly, I'm not versed enough in it to know where it's coming from that maybe aren't necessary. And so no hard feelings on our part if you pick that out for now. And again, as I said, when we were talking earlier, we were happy to help you guys prepare the data for the verification. So I know there are a few data points, but it seems like they're asking for some things that are pretty in the weeds that you guys probably don't easily have accessible anyway.
Yeah, I would say, I think we've tried it. The reports in the registry are just not what we need. So it's better to do manual working with your
Correct.
liaison anyway. So I agree, great that we're trying to get it up to what we want, but it's certainly not worth this.
Correct.
Well, and I can say that, as somebody who's worked in organ donation for a really long time, I don't understand what they're asking in some of those questions. I don't think they're worded very clearly. So I think no one's answering the same anyway. So I'm not sure that it's useful data.
So Trace, I think we've already did the shared experiences and celebrations. Did you have anything else?
I don't. I'm just celebrating the fact that I can eat and do my activities of daily living again. So does anybody else have anything they want to share? Oh, I know we wanted to, and maybe this, Kelly, one thing I wanted to do for all the committee chairs is to recognize your work because you're doing this over and above your, normal day-to-day jobs. So this is, this is something where people have stepped up and volunteered to lead these groups. And so I really appreciate that the time and effort. And, when you get to talking about patches, the headaches that you run into. So thank you to Kelly and Kendra and, just all of you, Rama, Ashley, Crystal, all the committee chairs, the co-chair, Lynn, she's done a great job. The past chair, Jesse, who kind of is a great advisor. And this brings me to another point is that this is going to be the end of my chairmanship at the end of this year. So to be thinking about nominations and somebody else who may want to step into, we need to elect at the November meeting a co-chair. Lynn will step up to the chairmanship and then we need, or chairwomanship, we need a co-chair. And so, the nominations are open. And if you're interested in being a co-chair, to email Lynn and I, and we'll mention this again at the August meeting and talk about it. The basic thing is you just work with the chair to run the meetings and just make sure things go through. And so most of the agenda is set. The only part that really Lynn and I work on is trying to bring in, bringing in our partners from LifeLink, to some of the meetings and going over the different standards. Sometimes the standards don't apply to all the centers, but they're interesting to hear, to learn about the standards. And so that's something we've started, and we're trying to keep up with the list of standards we've gone over, and also sharing and keeping an open communication with one another. But we do need to open the nominations. So just be aware of that. Think about it. If you've got questions, you can call Lynn or I. We can be found on the GCTE contact list, and you can find our emails there too. But we do have those nominations coming up. Can anybody think of anything else we need to talk about? I know Kelly had spoken about the AIS coding course, and she was referring to a standard that's, again, always going back to those standards. For levels 1, 2, and 3, you have to have at least one person on staff that is certified in AIS coding. And so that's why we wanted to offer that from a state perspective, because there's not really a way to study for it. It's just something that you have to do and then understand the rules and how to code. And the best way to study for it, I guess, is to take the class again. And so that's what Kelly got together. And I do appreciate, that was a lot of work to get that going. And hopefully we're helping centers get more centered on looking at the quality of their data, and the injury coding, the procedure coding, and those comorbids. I can't emphasize how important it is to follow the definitions. Of course, inclusion criteria is important, and we always have a round robin email going. It seems almost weekly about should this person be included or not. Sometimes we include patients in our registry that may not meet criteria, but they received care or something, an event happened. So by NTDB standards, they don't meet inclusion, but because of the care we as trauma services gave, we want to track that care or that person's outcome. So we keep them in the registry. So it's not sometimes understanding it, but thinking about what is the reason that you want to keep or have a person in the registry. Ideally, you don't want to put a lot of extra in there because you don't need the work and you don't need to pad your numbers because you can't turn those in or count them when they ask for different reports and stuff. So I'm just kind of going off on things that have been happening at our facility. If anybody else doesn't have anything to share, I think we're about through. Lynn, do you see anybody who wants to say anything or any comments?
No, I don't. Anybody? No, I don't think so.
Okay. Well, I think that's it. And we can give you 6 minutes back in your day.
Woohoo.
Woohoo. Thank you
Thanks,
for,
Tracy. Feel better.
thank you. We stand adjourned.